Good afternoon. My name is Bonnie Hibbs, and I'm Women's Health Resource at Baptist Health Louisville. It's my pleasure to introduce Matthew LaRocco. Matthew currently serves as Harm Reduction and Community Outreach Specialist at the Louisville Metro Syringe Exchange Program. He majored in Bible and minored in Disabilities Ministry at Johnson Bible College in Knoxville and is a certified alcohol and drug counselor. Matthew is a frequent speaker on a variety of substance abuse issues, focusing on harm reduction strategies. And he told me to tell you his kids like him.
That's right, yeah.
Please welcome Matthew LaRocco.
So it's always fun when you go somewhere and it's like doctor, this guy, right? And then it's like Kentucky Office of Drug Control Policy, doctor. So this is the good news. The bar is really low. And if you know me, I wore nice pants today. So I've already, like, if you've seen me out and about, you know the joke, because basically I only wear jeans. And I wear a black polo shirt because they make me wear a polo shirt. If not, I'd probably roll around in a t-shirt. And then I have some signature, like, Adidas kicks that I wear. And so I look nothing like a professional most of the time. But it's really excited to be here with you guys. I am Matt LaRocco. I work for the Louisville Metro Department of Public Health and Wellness. I run our Syringe Exchange program. I'm a certified alcohol and drug counselor. I'm also nationally certified to train for the Harm Reduction Coalition. But more important than all that stuff, I'm a person in long-term recovery. And so what that means for me is since June 15th, right, thank you, because some people, you're like, I'm a person in long-term recovery, and one person's like, and I'm like, do you not know how hard that is, right? Like, it's not easy. Not everybody can do it. Right? And so anyway, so I'm a person in long-term recovery. What that means for me personally is I haven't used any drugs or had alcohol since June 15th, 2009. And additionally, what that means for me is everybody else got clapped for at the end of their presentation. Just saying. Dr. Weeks, just saying, right? What that also means for me is I get to be a husband, right? I get to be a dad, I get to be a great father, I get to love kids, I get to love people who use drugs, and I get to love people who don't use drugs, and I get to be somebody who contributes to my community instead of somebody who really took from it a lot. And so I'm really excited about recovery. I'm excited about my recovery, and I'm just excited about being here. It's a privilege for a guy like me to stand up in front of people like you and talk about how we can serve people who use drugs and hopefully improve outcomes for moms, their babies, and then eventually you guys as medical staff too. So we're going to look at the objectives real quick. You guys can read because most of you work in the hospital, so I really hope you can read. So I'm not going to go over that. I do want to talk about goals. And so the objectives is like what I'm going to talk about and what you should walk away and know. But my goal for you and our time together is a little bit different. My goal is just simply this, that you think about how you think about drugs. Right? So we all have how we think about people who use drugs and how we think about recovery, and we think about treatment, and we think about moms, and we think about babies, and we think about all these things. And all I want you to do by the time that I'm done with my 45 minutes or so is that you think about how you think about those things, and that you make that a daily practice. That it isn't something that you just say, I know this, and I'm really rigid and solid about this. But every day when you get up and you go to work and you think about people who use drugs, or about recovery, or about treatment, you would stop and think about what you think about it. That you would continually be willing to grow. So I hope you hear something today and you go, that guy is wrong. Because it'll make you think. And I hope you hear something today, we go, I didn't think about it that way before. And I really hope you hear something and you come up to me later and go, Matt, I don't really know if I agree with you, and this is why, because that gives me a chance to think about how I think about drugs and people who use drugs. And so I want to just encourage you today to do that and just continually do that. Continually be growing and thinking, because here's the reality about drug use and how we work with people who use drugs. If you were an expert 15 years ago about recovery and treatment and drug use, right? How much of your information as an expert 15 years ago is true today? Not a whole lot. Because we learn more about drugs and how drugs work in the body, and then not just the medicine and the science behind it, but we learn about how it plays out in real life and that people are different. And what works for different people is different in your culture and your race and your socioeconomic status, and all of these things play into drugs. And so the reality is I know a lot about drugs. And I'm guessing probably in 15 years, I'm going to look back and go, man, I can't believe they let me talk in front of people because I didn't know what I was talking about at all. Here's the good news. If this is the worst presentation you hear all day long, there's a picture of a cute baby, right? We all love cute babies, right? This is my daughter, Sloan. Sloan is 8 weeks old now. If you're working the Baptist East NICU, would you just raise your hand real quick? Thank you so much. Our daughter spent 12 weeks with you guys. We just felt so loved. It was such a as good as a NICU experience could be, as wonderful as it could be, it was wonderful. You guys are just so great. I appreciate you guys so much. And Sloan's doing great. She's over 10 pounds now. She doesn't sleep as much as I'd like her to, but she's a sweet, sweet girl. And then anybody here from Women's First by any chance, OBGYN? Anybody you guys here? No? Well, they're a wonderful OB office, and they did such a great job for us too. So just in case, at the end of this time you go, this is terrible, it was no good, we need only doctors, at least there was a cute baby, right? And that's got to count for something because you guys love babies, right? All right, good. So I want to go through just a couple terms real quick. I really want to challenge you on your thinking. I want to encourage you to stop using the word addict because we don't define anybody else in society by one thing about them. Like we don't walk up to somebody and go, Jew, black, gay, young, old. We don't walk up, and you don't walk up to me and go, man. My kids do. They're like, man. But you know what I'm saying? Like, we don't do that, do we? And we don't want to be defined by just one part of who we are. Like, I don't want to just be white. I don't just want to be a man. I don't just want to be straight. I don't want to be a husband or just a father. I don't want to be a drug counselor. I'm all of those things, and I'm pretty cool. So, like, really, if you're going to, I'm like, pretty cool. That's, if you want to go with that, that's fine. But, like, I have all of these different things about me that makes up me, and I don't want to be relegated to one thing about me, especially when that one thing about me might be the worst part about my life, the thing that I feel the most shame about, or I feel the most guilt about, or the thing that I get stigmatized the most about, right? And so what I encourage you to remove that word from your vocabulary, and maybe you say people who struggle with addiction, or people who deal with addiction, or people who have addictive issues, or people, we could just do DSM-5 and go people with an addictive disorder or a substance misuse disorder. That would work fine too, but people come first. And when we talk about people who use drugs, they're people who use drugs, or they're people who inject drugs. They're not ID or IV or whatever. They're people, and they use drugs. And it's part of who they are, and sometimes it is a large defining part of who they are in the moment when you're spending time with them, but it is not the entirety of who they are. And so for all of us who just don't want to be defined by one thing about us, and maybe the worst thing about us, might we not do that to other people? Especially people who, when they're stigmatized for that one thing about them, go further and further and further and further into a disease or a disorder or whatever you want to call it that makes their life worse and their family's life worse and the community's life worse. If you can walk away from anything today, if you just stop saying the word addict, I would count that as a win, and that would be great. So when we talk about people who inject drugs, people who use drugs, Syringe Access Services, Syringe Exchange Program, and then our LMSEP, because sometimes saying Louisville Metro Syringe Exchange Program again and again and again is tongue-tying. So we're going to talk a little bit about how we got started. So basically everybody should be pretty familiar with some of the statutes that were passed last year that allowed us to practice, have syringe exchanges. And so they basically said, as long as you get a local support, you have the health department, the local board of health, you have the local, whatever the governing council, be it a board of magistrates, or it be, in us case, it'd be the city council supports that. You can start a syringe exchange program. It can be run through the local health department. So we started that last year, June 10th of last year. We were really smart about how we started it. I'm going to just brag on, and not on me because I'm not the brains behind this thing. I'm just the brains behind it now, right? And so when we started it, we said, instead of going, we know what we're doing, we're going to start a syringe exchange. We got everybody in the community together at the table. We gathered a bunch of different people from a bunch of different disciplines and said, let's talk about what syringe exchange should look like, how we should offer services. We even brought in the National Harm Reduction Coalition from out in New York and said, hey, will you guys work with us? Just to give you an idea of our partners, just wide range from methadone treatment centers to AIDS Interfaith Ministry to a bunch of Louisville Metro agencies, U of L, 7 counties, VOA, Walgreens. We had a lot of people as a part of this program. The outcome of that is we managed to not make a bunch of really stupid mistakes that people make. So we got some bad press at the beginning, but I'll tell you, I think one of the reasons that we didn't get a lot of bad press is because we by-stepped some things that new programs usually do, and then because we had so many people working with us, we were able to think about a lot of different things that allowed us to have a successful program, which would be a suggestion when we look at moms and we look at babies. We would go, man, wouldn't it be great if we took a multidisciplinary approach to treating them? And so bring in CADCs, and let me just throw something out to you. You and I are actually not experts on the lives of people who use drugs. You know who's an expert on the life of someone who uses drugs? Someone who uses drugs. And so when you're developing hospital policy, I might talk with someone who used drugs about, hey, if we did this, how would it affect you? How would it affect you coming to our hospital? How would it affect you receiving services from our hospital? Because you can talk to me, and I'm going to give you some pretty good insight. But someone who's actively using is going to tell you exactly, if you do that, how it's going to make me feel. Sometimes we miss that, but that's a really, really good thing for us to do. Looking at the services we provide, we give access to safer injecting supplies. So real quick, cookers, cotton, tourniquets, and water. If you don't know how to shoot dope, Google it, all right? You'll figure it out. It's not that hard. So we do that. We also do Band-Aids, antibiotic ointment, alcohol swabs, some different things like that, sharps containers, those types of things. We do all of those things because all of those things are necessary for HIV and hepatitis C prevention, right? And so if you give people fresh needles, but you don't give them cookers, and they still share cookers to cook their dope, and someone sticks a dirty rig in a cooker, that's the best thing about being here. Everybody's been like heroin and methamphetamines, and I'm like dope and cookers and rigs, right? So if you take dope as heroin, a cooker is a little metal thing that you cook it with, and a rig is a needle, right? And so when you stick a dirty rig in a cooker and you pull it up and you had blood on your needle, guess what's like in the cooker now? Hepatitis C for everybody, right? And so that's not good. And so if I just give you a needle and I don't give you a tourniquet or water or cotton, because you pull up like dope through the cotton so you don't damage the needle and you pull the particulates out, right? And so if I don't give you all of those things and I give you needles and then you share that other stuff, people get hepatitis C, which is why people, it's really funny, people who come and use drugs will go, well, I know you can give hepatitis C to yourself. And I'm like, dude, you can't. And they go, no, you can because I did. And they go, why do you think that? Well, because I never shared a needle. And I go, hey, man, have you shared a cooker, a cotton, a tourniquet, a wire? They go, oh, yeah, I've done that. There you go. And so literally we argue with people. I'm like, man, I can Google it for you. Will you believe Google? If Siri says it, will you believe me? But they're like, so we're very expansive in what we provide, right? We do hepatitis C and HIV testing, medical and mental health referrals, addiction treatment referrals, and then this is the great thing, they have access to a certified alcohol and drug counselor, and I tend to think that the certified alcohol and drug counselor on staff is really, really good at his job. I'm just saying, it's a fantastic guy. He's real cool, right? All right, so I want to run you through some real quick year one stats. So when we look at our year one, we had 13,000 visits, right? So that's not 13,000 visitors, but that's 13,000 visits of people coming through the door. We had about 3,679 new clients. Of that 3,679 new clients, 1,729 of them were returned, so they came back, right? So we had at that point at a year about a 47% return rate, which is really good. We gave out 415,000 syringes and we got back 245,000. That's a really good return rate for a program like ours. Most people think that, but when you think about it from this perspective, right now about 75% of the needles that I give out to return people come back. So if I give out 4 needles, I get 3 back to someone who's coming in and out of the program regularly. When I get somebody new that's come in, we give them a week's worth of needles, right? Because we don't want them to reuse or share because there's some significant issues that go along with that, which we can talk about at a later date when I have way more time. There's some significant issues that go with that. So when I come in and I have 1 needle and I'm getting 40 needles, you can imagine that throws off our numbers a little bit, right? And so when you look at people who are actively engaged in the program, we have about a 75% return rate, which means that when we hit saturation and we're not taking in, I kid you not, 80 or 100 people new a week, every week now still. Sometimes I take in 20 or 25 people a day brand new. When we hit saturation and we're going to see now not as many new people and we're going to continue to have more return people, we'll probably see our rates go up to about a 75% rate across the board. Right now we're still taking in so many new people that it brings that rate down. Age and gender, it's pretty wide. I mean, we see really, really young people, 18. We see really, really old people, 60, 70. 33 is about the average age. About 36% is female. 62% of them are males. Sexual orientation, 90% of people are straight, about 4% of people are gay. That bothers me, not because they're gay, but because that's not an accurate representation of the population that uses drugs, okay? So we really, when you look at the gay community, there, especially among men who have sex with men, there's a really high use of drugs, and we're not seeing those people. And so that concerns me as a program and lets me know when we move forward, we've got to do something to have better outreach to that community of people. Race, about 92% of the people that come to our program are white and about 5% are black. That also concerns me because 5% of the people that live in Louisville are not black. There's way more than 5% of the people in our population. I think we're like 20, 23, something like that. And so when we don't have an accurate representation of blacks or African Americans in our program, that means that we're not doing a very good job bridging some of the cultural barriers to engage African American people into our program. And so that's something that we're looking at and go, man, we've got to do that better. About 97.6% of our people are non-Hispanic. And then, and this is a really interesting rate, like 1 out of every 3 people has a job. Technically, you don't think about that when we talk about people who use drugs, but 1 out of 3 people that come to our place are employed. 56% of them have Medicaid, another 13% have private insurance, and then the majority of our people are uninsured. That 0.84% is usually VA. Drug use, 76% of our people, and so when we ask you, we just simply say, what is your drug of choice? And then you just say what you want to say. So some people say 1 thing, some people say 2. But 76% of our people, their drug of choice is heroin, and then the other big one is going to be methamphetamines at about 15%. Cocaine, other opioids, not so much. So people who use coke use a lot of coke. Referral sources, this is, I think, is the number that we're the most proud about. 68% of the people that come into our program are from friends and family referrals, right? And then another 6.77, so right about like 75%, 3 out of 4 people who walk through our doors because someone said, hey, you should go there. And we'll talk about that in a little bit, about why that makes us more effective when we work with people. And then services summary, we did about 316 Hep C tests, 376 HIV tests. We had 139 Hep C positives. We referred 203 people to Hep C treatment, which you think, well, how does that work out? Because we have people that come in that already know they're Hep C positive, but they're not engaged in treatment. So if you're not engaged in treating or monitoring your Hep C, we're going to continually be talking to you about what steps you can take to treat and or monitor your Hep C. Same with HIV. We had 2 positive cases, but we reconnected 10 people to care. One of the things I love about our location downtown, we are literally a block and a half from KCCP, so like the 550 clinic. We literally walk people. When you have an HIV positive result, what's probably going to happen if you want to go to treatment is we're going to hold hands, or I'm going to put my arm around you, and we're going to walk that block and a half to KCCP. You're not going to go there by yourself because that's a long half a block walk. And so we're going to walk you there, and we're going to make sure that if you want to get engaged in treatment for your HIV, that we're going to make it as easy as possible, and we're going to go with you and walk with you so you can get engaged. And so when we go, they know who's coming, and we go, hey, this is John. John just tested HIV positive, and I just wanted to know you, and this is a safe place, and they get greeted with a smile, and they get engaged in treatment for their HIV, which is awesome. So I want to talk to you for a minute about benefits. So the first benefit, and this is really the biggest one, is we provide a safe space for participants to discuss their pregnancy. So that, once again, going back to that 3 out of 4 number, I want to give you guys a little thing to think about. So there's this thing in hospitals called privileges, or I'll come over here and talk to you guys now. So there's this thing in hospitals called privileges, right? And because I watch Grey's Anatomy, not because I like it, but because my wife likes it, I like it, right? So I watch Grey's, I know what privileges are. And privileges are, in a hospital, it means that somebody has decided that you're appropriate to practice medicine in the hospital, right? You know what you're doing, and you're trustworthy, and so you're allowed to practice medicine in the hospital. Sound about right? Okay, that's privileges. Here's the catch. We have privileges with the people that we work with. Most of them trust us before they even meet us. We have people that come in now, we've been around long enough, and our work that we do is so good that when people come in and they see me, they go, you're Matt. And I'm like, yes, I am. I've never seen you before in my life. And they go, I've just been looking forward to meeting you. And I'm going, cool, man. Why? Because my friend told me you were a really nice guy. My friend told me that you loved people like us. My friend told me that I could trust you. And if we've had people that walk in, they bring their friends and go, this is Matt. Matt's legit. you can listen to anything he says and tell him anything, and you're going to be all right. That's a great referral. I had a guy that came in the other day, blew my mind, because when we think about drugs and people who use drugs, we don't think about this. This guy came in and he said, oh, man, you're Matt. I'm like, yeah, dude, I'm Matt, and you're John. Cool. And so he's like, I was like, how'd you find out about us? And he goes, man, my friends, they come here, and they said some really, really good stuff about you. And this is what he picked out of everything that they said. He said, they said you're a family man. Now think about that for a minute as mind-blowing. We think about people who use drugs, and we rarely think about people who value family, right? But this guy's friends thought one of the most impressive things about me was that I talk about my wife and my kids, and it's very, very obvious that I love my children, and I love my wife, and I love my family. If any of you know my wife, Brandy LaRocco on Facebook, just be like, I don't even know you, but your husband said he loved you in public, and you're cute, right? So my wife is beautiful inside and out. So I love my wife. I love my kids. And the people who come to our program know that. And they thought it was so valuable that they told their friend. And their friend thought it was so valuable that he came in. And he said, one of the reasons I came in is because you value family. If that doesn't make you think differently about people who use drugs, I don't know what will. Because it kind of blew me away. Another thing that happened is I have a public Facebook profile so our people can follow me. I just don't post our address or pictures of my house. And I've been on, paternity leave for a while. I had a bunch of time, so I took 6 weeks off and hung out with my kids, which was awesome. And so I get back, and one of the guys looks, and it was a guy too, he looks at me, and he goes, hey man, how's your daughter? I'm like, dude, she's doing really, really great. And he goes, I've been following you on Facebook to see how she's doing. So this guy is taking time out of his day to look at my Facebook profile to make sure my daughter's doing okay and that I'm doing okay. And then when he sees me, he checks on me, and he lets me know that he's checking on me. What does that say about people who use drugs? But what it says about us is this, that we have privileges. And you all are very, very nice people. But most of you don't. And it's not because you've done anything wrong. It's because they don't know you. And because you wear scrubs to work, or you have a fancy title, or you have some level of power or control over what happens to them or their children, they don't trust you. It's because they've had negative experiences with people like you. And I'm not saying that's your fault either. We'll talk about that in a minute. But they've had negative experiences with people like you, and they don't trust you, and you don't have privileges. And what that means is there are things that you need to say and you need them to hear that they will not listen to you. But they'll listen to us. And so when we talk about pregnant moms and babies, if you would let us know what you want them to hear, we will tell them. We will work with them because we have privileges. And we also will work with you to develop your level of privileges that you have. We do that for free. And I'm even more entertaining when I'm not in khakis. All right, next thing we do is early intervention. I really need to pay attention to the clock because I'm going to get myself in trouble, right? I need to be done by what, 2? Yep, somebody 2, right? Is that about right? Or 7 tonight, whatever. Early intervention in connection with prenatal care, so that's really important. Connection to addiction treatment, we reduce risk of HIV and hepatitis C, and we talk about safer drug use. That's going to trip you out, but it'll be fun, trust me, when we talk about it. All right, so connection to prenatal care. We know that people who use drugs, right, women, are less likely to either A, get prenatal care, or get prenatal care in a timely fashion, right? Everybody's aware of that? If you didn't know that, raise your hand. Don't raise your hand. Don't raise your hand. We'll all judge you for that, right? It's not a safe space here, and I'm joking. So, all right, but we really probably would judge you, right? And so if you use drugs and you're a lady and you're pregnant, you are less likely to get prenatal care or get timely prenatal care. And so stigma, maybe fear of the involvement of child. Where's my CPS people? It's not your fault. I love you. I love you. It's really not your fault. Y'all are wonderful people. Some of you are buttheads, but some of us are buttheads too. That's all right. Really, though, CPS, you guys get a bad rap, and I hate that for you. And I'm on your side for what it's worth most of the time, but generally, I talk good about you guys. Fear of involvement with child protective services, and then fear of legal consequences are all reason that women might not want to get prenatal care. And so what we do is when they come and talk to us, they can process that. They can talk about that. They can talk about why I'm not getting prenatal care, why I don't want to go, because they have a safe place to discuss that. One of the things that we do, one of the things that I say, and I've really learned to change this, usually when people are like, oh, we're having a baby, but I'll go, what? Oh, congratulations, that's so wonderful, right? And then when people come to the syringe exchange and they have a baby, I go, how do you feel about that? And so generally, everybody who comes to the syringe exchange, when they say, they're going to have a baby, right? And I'm having a baby is not necessarily that way because they're not excited about having a baby. It's because they know there's a lot of shame and stigma involved with having a baby. And so they might go, I'm having a baby. But they're actually excited about it, but they don't want to act excited about it because they might be afraid somebody would judge them. And so I just started with, how do you feel about that? What's your game plan? Have you thought about when the baby gets here what you would like to do? And we have some of those conversations, and then we talk about, well, so you're gonna keep the baby? Great. Okay, that's cool. Do you have an OB? No. Let me tell you a couple that you could go to. Real quick, we like to do like referrals for OBs, and we like to say that these people work really, really well with people who use drugs. So if in your office you go, man, we really like working with people who use drugs. We love them and we love their babies, and even though they're a little bit difficult, that's okay. We love them anyways. If that's your OB, if that's who you are, you should give me your business card and I will refer people to you. It's a win for you, right? Okay? And so while people come in and go, these are some OBs that we know do really, really good work with pregnant women who use drugs. And so we talk about what are some of the barriers, and we help them process through and work through those things and lower thresholds and eliminate barriers so then that they go to prenatal care. So what happens with the syringe exchange is a syringe exchange for women is an access point to prenatal care, and hopefully earlier prenatal care than later prenatal care. We also give them education about what kind of addiction treatment options are available for them as pregnant women. When you can go to treatment, where you can go to treatment, what might work for you, what might not work for you. And then that's a really limited conversation because I'm not a doctor. So I basically say, you can do this, or this. And if you want to do this, you should talk to Dr. Weeks. Or if you want to do this, you should talk to Dr. Jorish, right? And we kind of make referrals like that. So we don't get, we try to put our shovels away and not dig in areas where we shouldn't be digging. We give some pretty good referrals pretty quick. But we'll talk about just some different things that might be available to them. We talk about some of the myths, right, that are associated with treatment methodologies. And then we say, okay, so now we've worked through the myths, we've worked through your cares and concerns, and we've kind of gotten rid of some of the inaccurate or incorrect information. Most of them are going, yeah, I think I would be interested in going to treatment. So generally, when someone comes to the syringe exchange and we find out they're pregnant, they leave the door with a referral for OB care and treatment. And most of them are pretty motivated to go at that point. We reduce HIV and hepatitis C risks. So we know that syringe exchange reduced transmission of hepatitis C by about 50% among people who inject drugs. HIV rates have been shown to decrease as much as 80% in areas with syringe exchange programs. That's pretty good. That's pretty good. The great thing about hepatitis C and HIV is if you don't get hepatitis C and HIV, you don't have to worry about transmitting it to your baby. But that's actually really, really good news. And what's even better is if you get an HIV test and you know you're positive, you can go get ART. And then you can have like a 1% risk of transmitting HIV to your baby. And so you don't have to worry about raising a child. Not only do you have to deal with your own addiction and the shame and stigma that goes along with that, and then about having HIV and the shame and stigma that goes along with that, but now about having a baby who was born exposed to drugs and then also has HIV. Can you imagine what it would feel like to have all that going on and get clean? That'd be a lot, wouldn't it? And so we can offer them the opportunity to not have to worry about those issues. So pregnant women, they receive HIV testing, and if they're positive, we connect them to prenatal care, and we connect them to KCCP so they can get started on HIV treatment regimens, and so they can reduce their risk and they can reduce risk for their children. Safer drug use, they're like, what is that all about? So here's the deal. No drug is safe to use during pregnancy. Like no illicit drug, right? It's not safe. And so notice the The is a very important part of this conversation. If you don't hear the you'll not like me. Okay, so there's So when we change the what and the how of drug use, what happens is a lot of the harmful consequences associated with that drug use for mom and for the baby, they tend to be really reduced. And so when we look at the what, we could say there's no illicit drugs that are safe to use during pregnancy, but some drugs are safer than others, right? So we have like a whole schedule of drugs, and I don't have it memorized because I'm not a doctor, right? But there's like, this is okay, this is kind of sketchy, this is bad, right? And then we don't know, right? So we have like this, that we can say you can have this, but you can't have that. The same thing works with drugs. Now, and we kind of have like a hierarchy. Our hierarchy right at the top would be like tobacco and alcohol. Amazingly enough, those are some of the most damaging drugs for pregnancy. You wouldn't think it. Well, you would because that's what you do for a living. But everybody else wouldn't think it, but they are. And then you start to look at like amphetamines, methamphetamines, cocaine, and then we start to look at like injectable heroin, and then we kind of would drop down to like snorting heroin, and then we would look at pills from sketchy sources, and then we would look at pills that you know are actually what they are, because now they have like pill presses, and they're making like oxy 40s and oxy 80s that aren't really oxy 40s and oxy 80s. They're fentanyl and carfentanil mixed with God knows what, right? And so we would look at that, and we would go based upon what that drug is. We would go, this. For instance, if I had a woman who was injecting heroin and said, I'm not going to stop using drugs, but she had access to oxys that she knew were actually oxys. So she had a friend that got them. She could go to the pharmacy and get them with them. I would say it's probably safer for you to shoot oxy than it is for you to shoot heroin, because you'll know what you're getting every single time. You can regulate your dose better. You're not going to have the cut or the fillers, and you're really going to reduce your risk for infection. Now, I'm just going to throw this out there. Just thinking about things, blood sepsis is really bad for babies. I'm not a doctor, and even I know that, right? And so I'm going, if we can reduce your risk of injection drug use by getting you to inject a different drug that doesn't carry the risk of infection with it because of what's innate in that drug, we're going to reduce the risk that has on you and your baby. Or another example would be the type of drug that you use depending on who you are. And so I might look at somebody who uses methamphetamines, and they go, Matt, every time I use meth for 5 days. I don't sleep for 5 days. I'm going, I'm not a doctor, but I'm pretty sure if you don't sleep for 5 days, that's bad for the baby, right? Okay. And then they'll go, when I use methamphetamines, I tend to not really stay hydrated or eat. I'm going, I'm not a doctor, but I'm pretty sure if you don't eat food or drink water for 5 days, that's bad for the baby, right? And so I might look at somebody and go, methamphetamine, it's not going to be the safest drug for you to use while you're in pregnancy. And then I might talk to somebody else who goes, Matt, I use heroin, and when I buy it from this dealer, and I check the quality, and I use with this friend and that friend, I tend to only use 3 or 4 times a day. I don't have a lot of issues with overdose. But when I come over here and I use with my ex, I overdose every single time. Last time I checked, overdose is bad for babies. Like if mommy dies in the street somewhere, so does baby. And so I might look at her and go, so hey, if you're going to use heroin and you're going to inject heroin, it's probably better that you inject heroin with those people than you inject heroin with these people, because there's a much higher risk associated with it. Now, I'm not saying it's safe, but I'm saying it's safer. And when I'm dealing with somebody who's just saying, I'm not going to stop using drugs, I can beat the stop using drugs drum all day long, and guess what? They're not going to stop using drugs. But if I can have a conversation that moves their risk factors and reduces them and allows them to be safer about their drug use, that's a really, really good thing. And so we begin to talk about maybe you might want to be careful about how you use, not just who you use with, but how you use. So that's a big one also, the how. If I reuse a needle again and again and again and again and again, I'm going to build up scar tissue, I'm going to miss, I'm going to get an abscess, and then I'm going to get an infection. And if I don't get it treated, because I'm really not going to get treated because I use drugs, I have a baby, and I have an abscess, I'm going to get a systematic infection, and that's going to be bad for the baby, right? And so I might talk with somebody who goes, hey, if you're going to inject, then let's talk about doing this. Don't inject anywhere where you have any redness, scarring, tracking, bruising, inflammation. So good, clean, healthy skin. Clean with an alcohol swab before you inject. Only hit a spot once a day. If you're going to run a vein, go 1/3 to 1/4 of an inch between spots. Clean with an alcohol swab, fresh needle, Band-Aid antibiotic ointment afterwards for 30, 45 minutes. Now, if they'll do those things, guess what happens? Their risk of missing and having an abscess or having an additional infection really decreases significantly, because they're doing the same kind of thing that they would do if they were at a doctor's office. And so something as simple as cleaning, fresh needles, rotation, Band-Aid antibiotic ointment afterwards significantly decreases the risk for infection. And here's a big thing. If we can teach them to do that and we can connect that to caring for their baby, what's happening is they're making a change in how they inject drugs. And if you work with people who inject drugs, you will know that the injection process is just as sacred and addictive as the drug itself. People who stop shooting dope shoot water for a long time sometimes. They have burials for their rigs and their kits because that's how connected they are to them. I know people who've not shot dope for 3 years, and you know what they still have? trusty rusty, right? They don't get rid of their needle. They just can't get rid of it or let it go. It's so difficult. And so what we've done is we've gone into a part of the addictive process, their ritual for injecting, and we said, hey, let's change this a little bit so the baby benefits. And now what happens is mommy's made a change that benefits baby. And if we can help mommy make one change, we can help her make two changes. So everybody's good with the trans-theoretical model of change, right? Pre-contemplation, contemplation, preparation, action, maintenance. And so we can help you move through that process once. We can help you move through it again. And a really, really cool thing happens with this too. Generally, people do not let us talk about pre-contemplative or contemplative areas. They're not going to let you touch those at all, right? Unless they know that you love them and that you're trustworthy. Because if I want what's best for you and you believe that I know what's best for you, you'll listen to me. Now, if I want what's best for you, but you don't know if I love you, then you don't know that, right? And so if I love you, but you don't know that I love you, even if I have the best advice in the world, you're not going to listen to it because I'm not trustworthy in my motives, right? And then if you know that I love you, but I'm an idiot, my advice isn't trustworthy because I give bad counsel, right? But when you know that I love you and you know that I give good counsel, all of a sudden I become a trustworthy source of information. And that makes a really, really big difference when it comes to moms. And so when we help them navigate one change, we can navigate 2, 3, 4, maybe more. It's amazing how that works. People who come to harm reduction programs like this are 5 times more likely to go into treatment because of that process. And so what we do is we provide that safe space to discuss drug use. And here's the big piece. We allow them to make some informed decisions about their drug use. So we're not going to beat you up with the facts. We're just going to give you the facts, and we're going to let you make a choice with that. And the consequences are the consequences. But hopefully with good information, good education, and good support, you make some better choices for you and for your baby. So we're going to look at harm reduction for a minute. We're going to talk about how that works for our people, how that works for babies, and how that works for medical staff. So first thing about harm reduction, which is what we do as a Syringe exchange, it accepts, for better or worse, that licit and illicit drug use is part of our world and chooses to minimize its harmful effects rather than simply ignore them or condemn them. So I'm just going to look at people and go, listen, do people use drugs? It's going to happen. I'm not going to stop it, and collectively, we're not going to stop it today. So we can really condemn their drug use, or we could go, man, we need to do some things to mitigate the consequences to these people and the people that are in their circle. So that's harm reduction. It accepts that behavioral change is an incremental process. It doesn't happen overnight. Anybody ever go on a diet? Anybody gonna start a diet on Monday? Anybody been on 50 diets? Enough said, right? So behavioral change is an incremental process in which the individual engages in self-discovery. So I learn about myself and I transition through the stages of change. So what we're looking for is not this big, huge change. I stopped using drugs. We're looking for small, incremental changes that eventually, over time, when they're put together, make one big change and some significant changes in people's lives. Last but not least, it establishes, and this is going to be hard for sometimes in the medical community, it establishes the quality of individual and community life as a well-being as the criteria for successful interventions and policies. So a successful intervention is not that you stopped using drugs. It could be, but it's not limited to that. A successful intervention is your life is better and the community's life is better because of this intervention or policy. And it might be a little bit better, it might be a lot better, but it's still better. So it's not like I stopped drinking soda and I have diabetes, I quit eating bacon and I have heart disease, or I quit using drugs. It's I made small incremental changes that made my life better and the lives of the people around me better. So real quick, I want to think about that in just kind of 3 years, kind of with you out loud, about how that works for postpartum women. So here would be an example of what I would do in harm reduction with a mom who uses drugs in the NICU. You can't do this because you're doctors, but I can because I'm a harm reductionist. So I would look at a mom and go, here's the deal. You really need to not be high in the NICU. That'd be really good. Because when you're high, you're going to be loud, and the baby really needs you to be quiet, and the baby needs you to sit, and the baby needs to rest, and the baby really needs a reduction of stimulus. He needs to have not a whole lot of stuff moving around. So you need to be quiet. If you're high, when you're in the NICU, you're not going to be quiet. And you might also be a little bit combative because you're high. Also, if you're dope sick in the NICU, you're not going to be quiet. You're going to be irritable, you're going to be restless, and you're going to be more likely to clash with nurses. So you know that when you use a point of dope, so a point is 1/10 of a gram, right? And a point of dope is about $20. So 1/10 of a gram right now is running $130, $140, depending on where you buy it. If you use a point of dope, you know that from like an hour to an hour and a half, you're high. And then you know, like when you hit the 3-4 hour mark, you're dope sick. And you know there's a magical window between an hour and a half and 3 hours where you're not high and you're not dope sick, you're just level. That's when you should go to the NICU. So if you're going to shoot up an hour and a half to 2 hours before you go to the NICU. So when you're in the NICU, you're not high and you're not dope sick. So you can hold your baby and feed your baby. And that's good for baby, and that's good for you, and it's good for the nurses because you're not cussing somebody out. That's real positive, right? Would you guys agree with that? Right, so that's good. That's a small incremental change, right, that has some positive outcomes. I want to then bridge that gap a little bit more to think about positive outcomes from this perspective. Check this out. So when I use drugs and I'm a mom and I have a baby who is now dependent on drugs and has neonatal abstinence syndrome, right? So I have this issue going on, and you can imagine I don't feel good about that, right? And I don't feel good about that now, and I'm not going to feel good about that 5 years from now, or 10 years from now, or 15 years from now, or whenever I decide that I'm finally going to stop getting high and everything that I've done in my life comes back and I have to look at it. I'm going to have to look at that, and that's going to be something I've got to deal with to get me into recovery and to stay clean. What would happen if just in the NICU, right, we set up these little windows where moms who use drugs could do really, really good. They could do one thing and they could do it right. They could feed their baby and they could be a part of that process, and we could praise them for that. They could, for once in their life, not screw something up. What would it look like in 10 or 15 years when they're starting to make the decision to get clean and they go, you know what, I've messed up a whole lot of stuff, but I was able to do that part right. I did well at that. And if even when we look at drug treatment as a whole, if we could just set up windows where people could have little successes, small pieces of victory, what would happen is they could cobble those things together and they go, well, if I could do this and I could do that and I could do that and I could do that, I could do this. And so what's great about in the NICU is you could work with the mom. She could leave still using drugs and we're near recovery, and you'll never see it, but your interaction with her 10 or 15 years down the line will let her be clean and one day be a good mom to her kid. You'll never see it, but it'll happen. So we talk about babies. What would that mean then for that baby, right? What would it mean for that baby my brother is adopted, my sister's adopted, they're both adopted from a foreign country, they're never going to get to meet their mothers. And I've seen what that means for kids to not get to know their moms. I have a little girl that we've adopted from the Congo, and she is 6, and she is struggling with the fact that she's not going to get to see her mom. Imagine what it would look like for that kid when that kid turns 18 or turns 21 or 25, and they're going to start a family of their own, and they're dealing through some of these issues of what does family look like? And I know I have this family, but they're not my biological family. And what would happen at that age if they had a mom that showed up or a dad that showed up that was clean and was doing well and stayed clean for the rest of their lives? What would it mean for that child who's trying to figure out life, or that young adult who's trying to figure out life, to have that person come back in and go, man, I know I screwed up, but I've got it together now. And that will be a very messy, difficult process. But I know my brother and my sister would love to know their mothers. And they'll never get to. But you as a NICU nurse, you as a doctor, you as an OB, you have the opportunity to help that mom maybe in a little incremental way that later on down the life, even though she's not ready to be a mom to that child now, can be a mom to that child when the child's an adult. And I'm going to tell you something, as a 35-year-old adult, man, I still need my mommy and my daddy. Life is so much bigger than I am. And I rely on my parents, and every once in a while they buy me dinner, and that's nice. But being able to call my mom and go, my kids, I don't think they're going to live past tonight. And she'll go, Matt, you can't kill the kids. Let's talk about how you deal with that. Everybody who's a parent has had that conversation. Like, I don't know if they're going to make it out of preschool, right? You know what I'm talking about? That's when you know you're a parent. And then for medical staff. So I want you to think about this. I can't get into this really deep right now because I think I'm out of time. But I will come to your hospital and we will talk about this if you would love to, or your office, whatever. When one person out of 100 has a problem, the problem is that one person's, right? When 50 or 60 or 70 or 80 people have a problem, it's not just the problem for one person, it's a systemic problem, right? And when we know there's systemic problems, there's a pathology to those problems. Fair? And when we look at doctors and nurses in places like ERs and NICUs, guess what we know? You guys tend to have problems with people who use drugs. And for a long time, the recovery community has looked at you and said, you need to get your crap together because you're not doing a good job. And what I would say is it's really not your fault. If you're struggling with people who use drugs, it is not your fault. It's a systemic problem, and there's a pathology to it. There's a reason why you feel the way you feel, and there's a reason why you struggle the way you struggle. And there's some things that you can do that will make that better for you. Because one of the things we say in the recovery community all the time is, no one wakes up in the morning and says, I want to be an addict. I use the word, but that's just what they say. Well, guess what? No one wakes up in the morning and says, I want to hate one either. And at the heart of our hearts, you guys are caretakers. You guys are healers, right? And none of you guys like to dislike people. You don't like to hate people. You don't like tension and conflict with your clients and the people that come to your hospitals, right? And as a provider, someone who wants to help somebody heal, that does not feel good. And you go home with that, and you walk around the hospital with that, and you walk around life with that. And one of the things I love about harm reduction is not just about reducing harms for people who use drugs. It's about reducing harms for everybody who comes in contact with them. And so if you guys would like it, we would love to come and talk to you about how, as a hospital staff, you maybe could look at people who use drugs differently, think about how people use drugs differently, not for the benefit of the people, right? But for you. Because I love people who use drugs. And I love you too. And it breaks my heart that they're broken, and it breaks my heart that some of you guys are broken too. And if we could just heal brokenness on both sides of that divide, man, I think it would be a great thing for mommies. I think it would be a great thing for babies. And I think it would be a great thing for you too. Thank you guys so much.